Good afternoon. My name is Wesley Moore. I'm a nurse leader here at Advent Health Carewood, a community hospital in the Tampa Bay area located in Florida. Today I'm presenting my Practicum project, which is focused on improving compliance with guideline-directed discharge medications for patients who undergo percutaneous coronary intervention, otherwise known as PCI. This presentation will highlight the identified need, project goals, outcomes, stakeholder engagement, and the leadership and professional growth I experienced throughout this process. First, to speak about the organizational context. Advent Health Carewood is a 120-bed facility, also known as a community hospital within the Advent Health Network, a large network of hospitals that serve the West Florida division in Central to West Florida. The hospital's mission is extending the healing ministry of Christ, a faith-based facility which guides all aspects of care with a strong emphasis on patient safety, clinical excellence, and measurable quality improvement. Our cardiology program is an area of pride, but like many hospitals, we identified a gap in compliance related to post-PCI discharge medications, which presented an opportunity for meaningful improvement for our patients and our community. This kind of came out of the birth of our ACC accreditation, which involved really being very transparent and public about our reporting of metrics, which we'll go over later on in these next few slides. So here's the identified need. This need, again, was identified during our NCDR internal hospital abstractors. These reports showed that our compliance for all three required discharge medications, which include aspirin, a statin, P2Y12 inhibitor, such as clopidogrel, prasugrel, or Brilinta, ranged as a composite, meaning all three together. We were hitting between 73% and 89% compliance, which is well below the national benchmark of 100% at the 99th percentile per the NCDR. This means that a significant portion of our patients were going home without medications critical for preventing future cardiac events such as instant restenosis, thrombotic events, and other things of that nature, which could ultimately lead to death or disability. These findings highlighted a serious opportunity for improvement to ensure our patients receive evidence-based, life-saving care and also reduce readmission risk following the ACC guidelines. So the project topic and purpose. The purpose of this project was really to enhance the adherence to national discharge medication standards for patients undergoing PCI. Our intent was to align with the NCDR performance metrics, reduce variation in practice, and ultimately improve patient safety and long-term cardiovascular outcomes. This project also aimed to strengthen interprofessional communication and streamline the discharge process, not only for PCI, but other things such as heart failure and chest pain MI projects, all which are measured by the CMS guidelines, which also include a wide range of multiple disciplines, so it really was a large task at hand. So our goals. Our main goal really was to sustain or to achieve first and sustain 100% compliance for all three discharge medications as a composite. To reach that goal, we focused on making the discharge checklist easier for nurses to complete, ensuring that providers were documenting appropriately and reinforcing accountability across the care team. Education and communication were also key strategies supported by our daily huddles and routine audits. Again, we relied heavily on our abstractors to give us live data, and this was constantly fed to the nursing leaders and other team members and key stakeholders, which we'll go over in the next few slides. So stakeholders and collaboration. I think one of the biggest parts of this project was really getting the collective team together. So really the main stakeholders we had were cardiologists and hospitalists who drove the discharge orders and completed the medication reconciliation process. Nurses who really are the front line and see kind of what's going on. They verify and complete the nursing checklist and ensure that the physicians are doing their part as well. The informatics team had a huge part in this as we transformed into a new EHR, electronic health record. A few years ago, we saw a gap in the medication reconciliation process, and they were able to put in some hard stops there. And lastly, with our executive leadership, oversight and their resources kind of drove this whole thing together. So again, the success of this initiative depended heavily on collaboration Physicians, particularly cardiologists and hospitals, played a central role because discharge medication entry is a physician-driven process with the current electronic health record. Previously in old EHRs, it was nurse-driven. Nurses could do the medrec, but no longer going to be done in this new HR. Bedside nurses were instrumental in verifying orders and ensuring discharge readiness was reinforced with a previous implementing of standardization discharge checklist, again, that I'll share with you in we created some badge buddies for the nurses as well that we'll go over in the next few slides. And again, this met not only the PCI portion of patients, but other CMS tracked things such as heart failure and MI, chest pain. The informatics team, again, like previously stated, worked closely with us to embed reminders and streamline documentation in the EHR, which created hard stops for our hospitalists and cardiologists for these discharge checklists. And utilizing the executive leadership, the CMO directly worked with physicians, and the CNO worked with the nurse leaders on compliance and education for their frontline staff. All of this was kind of wrapped together in monthly multidisciplinary meetings at our cardiology committee, which helped maintain alignment, open communication as the project was kicked off. With a later iteration of a cadence, we were meeting monthly. We're now going to be meeting quarterly, allowing us to gather more data and kind of hit when we need to. So the implementation and interventions. Some things we've already discussed. We wanted to improve compliance. Several interventions were implemented. We simplified the nursing discharge checklist and added a badge buddy for quick reference, which we'll see on the next slide, making it easier to verify medications that were pertinent to the different health disease processes. The informatics team added EHR reminders to flag missing documentation, and we began performing real-time audits to catch errors before discharge. This really helped with the awareness level for the nurses on the floor, understanding what the PCI medications were and why they were important to our patients, which kind of bridged into the education sessions where transparent data sharing kept the team informed and engaged. One key challenge was that nurses felt overwhelmed by multiple steps in the EHR, meaning they felt kind of powerless as the medrec was kind of driven by the physicians, but they were held responsible for the bad outcomes. So really working with the CMO to empower our current physicians to drive excellence and do what's right for our patients was a huge part of that. Now we're moving into late November and December, where we've got some initial results, and we are really working on the sustainment portion of things. It does seem sustainable because now we have built-in reminders on the EHR, but we constantly going to be reassessing again, which we'll discuss later on. This is a sample of the new badge buddy. Previously it was all black and white, but these are now on the back of all the patients or all the nurses' badges. So they're able to quickly reference what medications they need to be on. So we can see PCI, which is that middle portion, aspirin, P2Y12, a statin, and then we also have outpatient cardiac rate referral, which is on a different slide. So what are the results? I was able to pull this from the NCDR data for 2025, and you can see the results have been very encouraging initially. Just as a quick reminder, the asterisk indicates that they're still abstracting that data, meaning there could be changes plus or minus. We just hope they stay in the positive marks. So our baseline compliance covered around 73 to 89%, as we can see in the red portions there of 2025, Q1 and Q2. But within the first 2 months of implementation, we were able to reach 100% compliance for Q3 of 2025. This improvement was largely due to the increased physician engagement and EHR process optimization. The entire team began to take ownership of the outcome, and our monthly reports now reflect initial improvement with sustainment on the horizon. Beyond the numbers, what this really means is that our patients are safer and our hospital is aligned with the national benchmarks with the NCDR. Because really in the end, it is about the driving the sustainment for the patients and making them healthier. So how do we create sustainment? We mentioned previously we had some initial success but we want continuous improvement. We want it to be sustainable. Really, with our quality improvement, we are driving for SMART goals, specific, measurable, achievable, relevant, time-bound in the PDSA cycle. So if you're not familiar, we'll do a quick brief overview. So PDSA is a Plan, Do, Study, Act. Plan is we identified a goal, and plan the change. Do, we implemented these changes on a small scale. Really, with a 120-bed facility, we were able to go hospital-wide with it. Study, we analyze the results and we compare to what we expected the results to be. In this study, they're doing really well. And then act is we decide whether to adopt it or adapt it. And here we're going to adopt the changes, but willing to adapt as new things evolve. And with the SMART goals specific, they have to be very clearly defined goals. We want 100% compliance, which is the NCDR metrics. They have to be measurable. Again, with the NCDR, we have to see what these goals are. Achievable, 100% compliance is a national standard. So we can see it is a very relevant goal. It may seem high, but when it's life-altering, you need to meet those metrics. Relevant, again, with the organizational context, extended healing ministry of Christ, and a drive for excellence and quality. Really, this was an important thing for us to do. And then time-bound. We can't have this going forever, so we need to see specifically when the time will be. And for us, we wanted immediate results, as we saw this is a high risk for our patients in the community. Like I spoke with earlier, we have a cardiology committee that's monthly, and we are switching that to a quarterly cadence. We'll report all this information, and we'll be able to collaborate and track as we see fit. Education remains ongoing. We meet with the nurse residents and give them information about chest pain, MI, and PCI patients, and we'll continue adapting. We know sustainment isn't a one-time task. It's an ongoing process of accountability and learning. That's why we have PDSA and SMART goals embedded into this process. What it is hardwiring it, and it's reasonable that this project is sustainable. To say it's sustainable, it's not person dependent, rather a process that is a multi-level and has a built-in hard steps within the EHR, again, which is drive this excellence. In the broader aspect of this practicum project, how have I been able to align myself with the professional goals and the AONL competencies? Really, the project aligned closely with the American Organization for Nursing Leadership Competencies. I strengthened communication and collaboration, exercised leadership to guide behavioral change, and deepened my understanding of data-driven improvement. Professionally, I learned how to balance initiative with empowerment. Leading without micromanaging was a big portion of this. I quickly understood that I couldn't go touch every single patient we have. I needed to rely on the frontline staff to make this happen, and trusting others to drive the success. Really, that's the key driver for all of that. So what does this mean for me and my lessons learned as a nurse? The greatest lesson I learned that is people truly are the power behind sustainable change. You can design the best processes, but without belief and buy-in from your team, it won't last. The project reinforced that leadership is about influence, not authority. When people believe in the purpose and see the value, meaningful and lasting change happens. I left myself with this kind of quote: people are the power. And what I mean by that is power teams drive and sustain change. You as an individual can want the best and do the most, but if you don't have the people who believe in you and believe in this process, it's ultimately going to fall through. Here's my references. Please respond with any questions or comments you have. I've enjoyed this class with you guys, and thank you.